AZCCC presents the Cancer Care Podcast. Joining us today from Arizona Center for Cancer Care and the VirginaGPiper Cancer Care Network, medical oncologist Dr. Clarence Adoo, along with Dr. Tafadzwa Makarawo, surgeon from the Colon and Rectal Center of Arizona.
So, docs, I assume that you know each other. Is that correct?
That is correct.
That is correct.
All right. The way that you're smiling, I'm taking it that you're friends as well as peers?
Absolutely.
We kind of get along. He tolerates me.
Okay. All right. So we have medical oncologist with AZCCC and VirginaGPiper Cancer Care Network, Dr. Clarence Adoo. First time we've met in person.
Yes, although your reputation is everywhere. So
Good or bad?
I know who you are. Very good.
Okay, good, because it's hard to keep up with a great reputation like yours. So, Dr. Adoo, welcome down. Good to have you.
Thank you very much.
Now, I'm going to do my best with the name, okay? Because I heard a fellow doctor call you Taffy. That's your nickname.
Correct.
So I'm going to say Dr. Tafadzwa Makarawo.
That's spot on.
Pretty close?
Very, very close.
All right, and today we're going to talk about colon cancer. Talk about who you're with and what you do.
So I'm with the Colon and Rectal Center of Arizona. Myself and my partner are two colorectal surgeons that specialize purely in the subject of colorectal conditions. That goes from all things that range from everyday things like pain in the butt, hemorrhoids, bleeding, then going to the more significant things like cancers and diverticular disease. So that's the kind of wide range of things that we look after, and we kind of manage them surgically and endoscopically as well.
And then, Dr. Adoo, you're the guy with the playbook. Somebody gets diagnosed with cancer, you're calling the shots in terms of their overall care, correct?
That's correct. So Dr. Makarawo's job is to prevent the cancer. He and his team and his group of physicians do a really good job. Occasionally, cancer slips through and it's a higher stage, and that's what we deal with.
The way that people are typically diagnosed with colon cancer, is that through a primary? Is it through a colonoscopy when they're originally diagnosed?
The reality is that colonoscopy has a big portion in terms of diagnosis. And I would say that a lot of patients that come in and have their screening test done, unfortunately may have already developed colon cancer. And then there's a portion of people that have it diagnosed as an emergency. So they come in through the hospital and they've got symptoms from it already. And that's the situation where it's a little bit more advanced. So they either have a bowel obstruction or bleeding or abdominal pain. And so those are the two extremes, either through screening or as a result of symptoms.
And obviously, the earlier that you can catch colon cancer, the better shot you're given to Dr. Adoo to help cure it.
Absolutely.
All right.
Absolutely.
Now, with the colonoscopy, do a lot of people come in once they experience symptoms, and that can be a sign of, man, you're coming in late. This is going to be a late-stage diagnosis. Is that typical?
The thing that I always tell patients is, in general, colon cancer is somewhat of a silent killer. About maybe 1 in 3 people have symptoms from a colon cancer. So, in other words, once you have begun to develop symptoms like bleeding and abdominal pain, usually it's a pretty advanced condition. Most people, when it's diagnosed, if it will be diagnosed, are actually asymptomatic. So that's why colonoscopy is so important, because to have it done, you want to try and catch it at a very early stage.
Do those always go together, pain and bleeding?
No, they can be completely independent, so it can be any combination of those symptoms. It's not always a combination of both. Sometimes it may well just be weight loss, which is unexplained. I've had patients that have come in feeling just really tired and worn out, and they've checked their blood levels and their hemoglobin is low, and we find out, lo and behold, they've got a cancer. That's a very common scenario as well. So it's often a wide spectrum, but the majority of people don't feel anything, and that's why it's so important to get it checked.
At the point you refer a patient to Dr. Adoo, it's not just like when you're taking a polyp off during a colonoscopy. How do you tell that the diagnosis is more advanced? And then Dr. Adoo, explain about how you treat it after that.
What we do typically is we do something called staging with any diagnosis, and this goes across the board with any cancer. That we do a process where we want to establish if the cancer is just isolated to the body part where we found it, or if it's gone elsewhere. And so part of what we do beforehand when we found the diagnosis of cancer is we do some x-rays, we do some blood tests. And if we found that it's begun to show signs of having spread, then that's when Dr. Adoo's role is critical, because there's a strong chance there may be a need for some kind of additional treatment. So we do the staging before the surgery, and then also after surgery, we check again to see if the cancer is just in the organ itself or if it's gone to the lymph nodes, which would then tell you again that there may be a need for chemotherapy.
And you do that with a pathologist?
Correct.
They check it
Yeah,
out.
pathology.
And Dr. Adoo, Talk about the different types of treatments depending on the stage of cancer that is brought to you.
Basically, for colon cancer, as for most other cancers, there are three things we can do. If the cancer is small and localized and hasn't spread, you take it out. You always hope that if there is a cancer diagnosis, it's at a stage where it can be removed.
What stage would that be?
That would be stage 1, 2, or 3. Even in some cases of stage 4, if the primary site where the tumor is bothersome, such as it's bleeding or causing a blockage or pain or discomfort, it might still need to be removed. So then that goes back to the surgeon, and the surgeon is the primary person and does the removal.
And would you be the surgeon on that?
Correct.
Okay.
Yes.
The other things that can be done for a cancer, and again, this is pretty much almost all cancers, is sometimes it's small and it's localized, or it's causing local symptoms in the place where it developed, but it cannot be removed surgically. Either it's too close to vital organs, or it's too difficult to get out, or it's a little bit deeper than it needs to be. Then radiation would be a way to treat it. And radiation is basically using X-rays that are intensified. If you think of a laser beam of light, like the light lasers that you can shine on a wall and get your cat to run after them and so on. So that's done by intensifying regular light. And you can do the same with X-rays. You can take an X-ray beam, just a regular X-ray that is done to do a chest X-ray, and you can intensify the beam of X-ray in the same way as you would for a beam of light to become a laser torch. And that intensified beam can be given at a dose that destroys cancer cells but spares normal cells. So that would be your regular radiation therapy. There's different variations on radiation therapy. And then sometimes the cancer may have spread or may have the risk of spreading to other parts of the body, places where you cannot get to with surgery. You can't cherry pick all over the body, or places that are just too far away. They've traveled through the bloodstream or through lymph nodes.
Well, then you're talking chemo.
Then you're talking chemotherapy, and nowadays there's variations of chemotherapy that use not just the chemical aspect of the drug, but also its ability to induce an immune response, and we call those immunotherapies, or sometimes it's a targeted drug, such as a drug that targets a specific molecule or a specific gene on the cancer cell, and we call that targeted therapy. But those are basically forms of chemotherapy.
Is immunotherapy thought to be less aggressive?
It's probably less aggressive in terms of its side effect profile, in terms of how intense a side effect might be. But there are still drugs that have to be given very carefully because they can have unexpected side effects. Not many, but they can be unexpected, and any one of them can be severe. So the spectrum of side effects is still fairly broad. But the traditional side effects we associate with chemotherapy, the nausea, the vomiting, the hair loss, the fatigue, and things like that, are generally not seen with immunotherapies.
Dr. Makarawo, Taffy, how resilient is the colon? When Dr. Adoo talks about radiation, how resilient is the colon? Because when I think of the colon, I think of a polyp contained within the colon, and being protected is probably a bad use of terms, but that it would be hard to spread to other organs through radiation, that it would harm the colon. Is it pretty resilient, pretty strong?
So one thing that I want to clarify, so when polyps are at a stage of what we call true polyps, the majority of them are not harmful and don't need the type of treatment Dr. Adoo would offer. It's when it gets to the cancer stage that it's become significant and it needs additional treatments, etc.
Yeah, a polyp isn't cancer necessarily.
No, so a polyp, the majority of the time, is completely benign and harmless, but it's the process with these polyps that's the problem. That's why we remove them, because we know over time there's a proportion of these that can evolve. And so it starts off benign, but over a number of years, it then evolves. We talk about between 5 and 10 years. And if it's not removed, then that's when you run into problems. To answer your question specifically, the colon resilience, I guess, is kind of a difficult thing to articulate without you physically kind of touching it and feeling it. But as an organ, just say that it's constantly evolving, it's constantly regenerating, because the process of having bowel movements going through it constantly is traumatizing it. So it's actually a very tough organ. But it's this constant evolution and regrowth of cells. That's kind of what happens when they begin to regrow in a way that's kind of out of control. That's essentially what cancer is, when it starts to kind of overgrow, and then you begin to get excessive growth, and you get a polyp, and then if that polyp continues to change and evolve, then it becomes a cancer.
And when excessive growth happens, Dr. Adoo, you mentioned that it can cause problems with other organs. Would it have to spread outside the colon to cause problems, or is it just the size alone inside the colon?
In general, it would have to spread. So the way a colon cancer would spread is most of these develop in polyps, as we've heard. Imagine that you are in a room, a tubular room that's like in the inside of the colon. The polyps are projections that hang into the lumen of the colon. So these are things you would see from the inside.
It looks like a teardrop almost.
Correct, yes. The common polyp would look exactly like a teardrop, and these hang on the inside of the colon. As they change from polyp to cancer and from early cancer to late cancer, they begin to invade the wall of the colon so that they penetrate a little bit deeper and eventually get to the outside of the colon. And then they can spread within the abdominal cavity. They can spread to other organs locally. The other way they can spread is through lymphatics. And lymphatics are basically the tiny, tiny little tubes. They form a very wide meshwork of tubes. Imagine the highways of Los Angeles or something like that, tubes connecting with each other and so on. Their primary purpose is to conduct extra fluid away from organs. So as the body works, different cells and organs in the body are bathed with fluids that bring the nutrients and all the things that we eat and the good things to the cells. And as they do their work, the excess fluid needs to be removed and sent back to the heart. And that goes through these tiny little channels called lymphatics. Now, these lymphatics, if you imagine the tracks of a railway, that each lymphatic will end up at some station somewhere before it continues on its journey to yet another station. And those stations are called lymph nodes. So as cancer travels along these, it goes from one station to the next and to the next and to the next. And part of what makes a colorectal surgeon a little bit different from a general surgeon for this disease is their ability to pick out these lymph nodes and get a sufficient number of them for the diagnosis if the colon cancer has to be removed, and also for the therapy to be able to remove them. Then there's the third way the cancer cells will spread, and that's just through the bloodstream. And although when they spread in lymphatics, you think of it like a railway thing, they go one station to the next, they don't really cross one station to get to the next. They have to go one step at a time.
It's always chronological like that?
Correct. When they go through the bloodstream, it's different. You can imagine if a bad guy got to Phoenix Sky Harbor and got on a plane, the next stop could be Honolulu. The next stop could be...
You have no idea where it is.
You have no idea.
Yeah.
And so when tumors travel through the bloodstream, they tend to end up in distant sites. So from the colon or for the rectum, the next site could be the liver, or could be the kidney, or could be the bone, or could be other sites. That's generally how these things spread, and that's how the staging numbers are determined.
So quite often, a patient could be receiving multiple treatments at one time. They could be getting radiation. They could maybe at some point an excision and chemotherapy. Or an immunotherapy.
That is exactly correct. In sequence or sometimes in combination.
You guys have seen it all. With the tumors, I have to ask, do they get so big they block the digestive tract?
Yes. When you asked earlier on about the way cancers can present, when the tumor becomes so enlarged that this tubular structure becomes completely closed off. So I give an analogy where the colon, liken it to being about the size of maybe 3 or 4 centimeters, maybe 5 centimeters in diameter. But when it becomes filled with tumor, or the whole space is consumed by tumor, then it ends up being about the diameter or the size of a straw. Sometimes it gets so bad that sometimes
The
patients...
whole digestive tract?
or that particular area of it where the tumor is.
So nothing can get through.
So
liquid
very
maybe.
little gets through, and eventually nothing gets through. And that's when obviously you're in an emergency situation, because the obstruction is obviously can be potentially life-threatening.
So at times when you mention to a patient that they can get an excision and possibly be cured, that's actually good news.
Yes.
That means that
exactly.
it's targeted, isolated, you can take care of it.
Absolutely. And just one more point. I agree exactly what he said about obstruction, but all of these things like obstruction and bleeding and so on, they occur on a spectrum. So there's complete obstruction where someone cannot pass any stool and they have abdominal pain and their belly gets bloated and all that. But sometimes it can be subtle. Somebody whose normal bowel habit is every day starts all of a sudden to go every 3 days or every 4 days, or somebody has a week when they haven't gone, and then explosively they have to go all at once, or somebody whose normal stool is a certain character and then it changes all of a sudden. So the traffic isn't always a complete block. If you lived in Awatuki and worked uptown like I used to, the Broadway curve is what
Right.
it is, and it's traffic. And if you have that traffic, it can manifest different ways. Same with the bleeding. Some people might see blood in their stool, and that always needs some attention. But sometimes the bleeding is so subtle that they might not know it for months or even for a couple of years, because they are bleeding at such a small rate that their body keeps making more blood to compensate until they lose iron stores, and then they become iron deficient. Then they start becoming really anemic, and by then it's been there for maybe several months.
At first, how would somebody know the difference between that type of blood and hemorrhoids?
One of the things that's very difficult, these are the life happens moments. Everybody has moments where they feel like they haven't gone for a few days. Everyone has moments where they have a bowel movement and they see a bit of blood. And so it's discerning between something that is serious and not. That's kind of the challenge. And the reality is that a lot of the times we often dismiss some of these things and kind of carry on. And most of us will be okay. The reality is that most of the time it's nothing serious, but it's for those few occasions when something serious is going on, when it's probably best to get checked out. It's just because, as Dr. Adoo was saying, there's a spectrum. There's obviously the extreme examples, but then there's also the very light examples where things just seem a little bit different. And maybe a lot of times when you're living your life, you tend to kind of just not think much of it. So that's why it's important to get checked out at that point.
With colonoscopies, it's always recommended, depending on the patient, 3 years, 5 years, whatever type of interval that you assign to the patient. During that time, hopefully, they're going to get physicals every year annually. Is colon cancer something that you can catch just through normal blood work with a physical, or does it have to be a colonoscopy?
Generally, the recommendations are based on age, and then based on your family history, and then to some degree based on whether you have any genetic predispositions. The age-based recommendations just based on the average risk, and most of us are within that category of average risk. And interestingly, the age that was always kind of talked about was 50. And then in the last 2 to 3 years, the American Cancer Society talked about reducing it to 45, and they actually put it in their recommendations. And then as of this past week, the American College of Gastroenterologists has endorsed that age as well. So in actual fact, I think the move has now been leaning towards 45. This is the recommended age for the average person. And that's mainly because of the increasing incidence of an increasing number of cases of colon cancer that are increasing in younger people.
So, Dr. Makarawo, a patient comes to you and you find a polyp. It's benign, but that means that they have to come in more often to get a colonoscopy.
Correct.
3 years, something like that.
And the rationale behind that is to check to make sure that no new polyps have redeveloped that need treating again. Because likely if you've got a polyp and you're the type of person that develops these polyps, you probably want to have them removed if they develop, to prevent them from growing into a cancer.
And Dr. Adoo, is that a sign by any reason that a patient is more suspect to having other types of cancer?
That's an excellent question. And scientifically, we don't know all the answers yet. There are risk factors for different cancers, and colon cancer, for example, will run more commonly in people of certain ethnicities or people who live in certain geographic areas of the world. that might be more severe in others than some. Even diet may have some influence, but it's very difficult to tease out because people who live in different parts of the world have different diets, and so it's hard to separate the effects of diet, what you eat from where you live and where you come from, and so on. And then there are families who have clearly defined higher risks than others. And colon cancer is a particularly important one in that way. If someone has a family history of early colon cancer, meaning they have a first-degree relative or even a second-degree relative who had colon cancer before the age of, say, 50 or 55, that person needs to be sure to start their screening much earlier than the average. We generally say about 10 years, 5 years maybe, for the development of colon cancer. So if your mother or brother or sister or your dad developed colon cancer at age 50, you want to start your screening at age 40, and you want to pursue that pretty carefully. Mm-hmm. There are also some genes which can be measured by gene testing.
Oh, interesting, like a breast cancer? Almost?
Just like breast cancer, exactly like that. And just like breast cancer, I can't mention gene testing without two quick caveats. So there's gene testing, which I'd probably call it prescribed or physician-ordered gene testing, which is based on a person's risk factors. A doctor sees them or their provider sees them and says, hey, you have a family history of this, let's check for that syndrome or something like that. Then there's gene testing where you can send away to a private company to have your chromosomes analyzed to see your familial heritage, or to see who you are related to, Facebook or whatever, or however people do it. And sometimes those tests will identify a gene that is associated with some syndrome. The medical community doesn't yet know what to do with some of those genes because the risk of a gene depends in part on who in your family has already had a certain disease. In other words, you might identify a certain gene mutation, which means nothing in one family, but in a different family means a high risk of disease. And the only way you'd know is if there was already somebody in the second family who had that disease. So that makes some of those gene testing a little bit complex.
That's fascinating. So genetically, as a patient, there's not much we can do. But you mentioned diet, and although diet is different all over the world, one thing in common is hydration. Do you find that, Dr. Makarawo, to be a big component that comes into a healthy colon?
Hydration has a big contribution to it, but fiber in the diet is probably the bigger of the two.
Consistently.
And the reason for that is fiber, which is found in certain foods, tends to affect the consistency of a bowel movement. So what we found through research, we found that essentially an increase in fiber tends to make your bowel movements of a slightly lower consistency or softer consistency. There tends to be a lower risk of constipation. Fiber also tends to provide nourishment to the cells of the colon. And for those multiple reasons, we found that obviously it's more of an association than a direct risk factor. Increase in fiber decreases your potential for developing cancer. And for those reasons, you get more frequent bowel movements, you empty out a little bit better, you provide the right kind of nourishment for the cells, because in this age where we talk about probiotics and prebiotics, the fiber provides a prebiotic portion. So that means it provides the right kind of nutrients that the cells of the colon thrive on, and that's how it allows for a maximum health of the colon. One thing that I talk to my patients a lot about, I think there's a lot that's said about diet and low fat in the diet and a lot of the other fads that are out there that talk about weight loss type diets, but I don't think enough is talked about diets that build good gut health. Increasing and maintaining high fiber is critical. The recommended amount of fiber that I talk about with patients is between 25 to 30 grams of fiber a day.
What is that? Give me an example what that is.
So to quantify that, if you were to have a portion of apples or an apple, that's about 3 grams portion of prunes would give you about 8 grams. Similarly, grapes would give you a very similar amount. If you look at a lot of packaging these days, it tells you the fiber amount. So a portion in either fiber bran or protein bar or in portion of vegetables, that gives you a rough idea of how much you should have. So 25 grams, it sounds arbitrary, but if you look at the foods that you have, you can probably get a good sense of it just by virtue of if you're maintaining good amounts of fruits and vegetables in your diet.
You want to be around 30?
About 25 and 30. And the average that we know currently is about 5 grams a day.
Wow.
And that's just a function of
Really?
how we eat.
Is that just junk food and...
Processed foods. So we rely on a lot of processed foods. Pastas are processed, pizzas are processed. There's not a lot of fiber in those meals.
So people are eating like 1/5 or 1/6 in the
of
normal...
the recommended amounts.
Oh, wow. That's fascinating. Being a curious guy, can I ask you a more dramatic question? When we hear about a portion of the colon being taken out, is that just due to the size of a tumor, to where it's so big that you can't work around it and you just have to take a large portion of the colon?
So, yes, sometimes it can be due to size, especially if it's invading and spreading outside of where the colon is. You may need to remove more of the colon for those reasons. What's more commonly the reason why you have to take out a portion of it is because it's down to, as Dr. Adoo was talking about early on, those lymph nodes, those highways that lead away from the colon. You want to try and be able to take not only the tumor and the piece of the colon, but you want to take a portion of those highways and lymph nodes to help with staging. And a lot of that is related to blood supply. So it's not good technique and good treatment and cure to just remove the small section where the tumor is, and you have to remove a section and a little bit of the surrounding areas on either side of the tumor to make sure that you get a good distance on either side of the tumor to ensure for cure, but also that you take a good amount of those lymph nodes and those highways to give us as much information as possible about the stage to then tell us whether chemotherapy or additional treatment is necessary.
The highway analogy is a great way for an average guy like me to understand and visualize what you're talking about. And another thing I'm getting out of this is you guys really are a tag team, because at the point of diagnosis, you send a patient to Dr. Adoo. You get the diagnosis that's already been possibly sent to a pathologist with a biopsy. You assign the treatment, and then it has to go to the pathologist again to make sure it's clear, and it could come back to you.
Correct.
So you guys are going back and forth all the time.
That's correct.
So you guys have each other on quick call. You guys
it's funny you say that. The usual scenario ends up being a text message kind of back and forth or a phone tag on a Friday afternoon.
I was just going to say that
just
Friday afternoon.
That's usually how it plays out. There's usually something that comes up. Either I've seen a patient that we have in common, or there's someone I've seen that I'm concerned about, or there's someone that I've just operated on and I'm pretty convinced they'll need the additional treatment. I usually give them a speed dial or a little message to say, hey, Mrs. Smith needs some help.
As a colon surgeon, is it frustrating when people don't come in for a colonoscopy just because they don't want to do the process or they don't want to think about it? Or is that old thinking? Do you even come across that anymore?
I would say heartbreaking is more the word. I think that for what it is, at the expense of taking a prep the day before that, yes, that's kind of cumbersome. I also recommend trying to stay on a liquid diet the day before. But for what it's worth, a colonoscopy, once you come in, takes about 30 minutes. You don't feel a thing because you're asleep, but it's life-saving. And I think a lot of folks that I've seen that potentially could have been saved a cancer really have done themselves a disservice by not coming, because it could have been prevented.
Yeah. Guys, what have we missed? We've covered a lot.
Well, I've learned something about fiber. And
you're going to be checking labels.
I'm
30 grams, man.
Labels,
I got to get through.
Yes.
Me too, Dr. Adoo.
I think the one thing that I think is trending is colorectal cancer in the young. Obviously, it comes to the fore in mainstream media when you see high-profile celebrities pass on, like Chadwick Boseman, who passed away. He was in Black Panther. So he was 42. But this is something that is definitely a big problem that's obviously on the horizon. An interesting thing that I read the other day was that depending on when you were born, as of people born after the year 1950, your relative risk of ever developing colon cancer has progressively increased. In other words, compared to people that are older, the younger people are having an increasing risk of developing colorectal cancer in their lifetime. So I think the things that will help us when they begin to decrease the age for screening, which is 45, and I think probably in the next 5 to 10 years, it'll probably go down to 40.
And why not? Well, I mean, what's the downfall to that? Why not?
Yeah, absolutely.
And I'm totally into preventative. Totally into that. All right, contact info. Dr. Clarence Adoo, medical oncologist, Arizona Center for Cancer Care. Just because I get to work with you all the time, I know it's ArizonaCCC.com. When you go there, it'll say find a doc, medical oncologist. First on the list, because Adoo with an A.
Yep.
First on the list. Thank you. It's a pleasure to meet you in person, too.
My pleasure.
Yeah.
My pleasure. Thank you so much.
Dr. Makarawo, give us your contact information, how people can contact you and find you.
So my office is based at the Colon and Rectal Center of Arizona, and we are in Glendale, just off the 101 exit 19. And we're at www.crcaz.com, crcaz.com. I'm available. I'm there 4 or 5 days a week, and between being in office and the hospitals, I'm around and I'm available.
This is the super duo, and because of you guys, for dinner tonight, apples, corn, prunes. Like Dr. Adoo, I'll be checking every label on everything I eat
Well,
now.
blame him for that.
Guys, thank you.
Thank you very
Thank
much.
you.
Thanks for listening, and please join us again for the Cancer Care Podcast, presented by Arizona Center for Cancer Care. For more information on the highest quality of cancer treatment in Arizona, please go to ArizonaCCC.com.